Bismillahirrahmanirrahim. Assalamu alaikum. As you all know, I have a channel that is Neurology Made Easy. So initially I started with making videos, short 3-minute videos with mnemonics and graphics so that I make it more interesting. The topics, because neurology is dry, but it's quite interesting. So I try to make it more interesting and to spread the knowledge. So my niyat is, my main aim is to spread the knowledge. But I felt that it takes a lot of time to make these videos. I will make these videos once I get time, but for now I'm trying something new. That is, I will discuss some topics through audio lectures. In this way I will revise the topic and I will also share it with someone who wants to listen. So basically I used to make a lot of notes, but each time I lose my notes and I have to make them again and again. So instead of doing that, I thought of sharing these audio lectures. So without wasting any of our time, let's go to the lecture. So in today's lecture, I'm going to discuss about anti-epileptic medicines. Basically, now we call them anti-seizure medicines because they are not only for treating they are not only for treating epilepsy, but also for seizures. And seizures are not always epileptic seizures, as you all know. So the drugs first I will discuss the common drugs with you, details about these drugs, and then we will discuss how we can choose a drug for any given patient. So the first drug I'm going to discuss is gabapentin. So gabapentin is basically used for partial seizures with or without secondary generalization. The exact mechanism of action is not known, but it is proposed that voltage-gated calcium channels are involved. Usual dose is 900 to 3600 milligram per day. Mode of administration is oral. It does not have much enzyme interactions. It is not an enzyme inducer or inhibitor. So it's good to use in patient in which we try to avoid this, like elderly patients, if they don't have any contraindications for gabapentins. The other thing is the side effects are fatigue, headache, nausea, dizziness, ataxia. Excretion is mainly renal, and important thing is gabapentins have non-linear absorption. By non-linear absorption we mean that they are absorbed, but at one time there is saturation of the receptors and it is not further absorbed, so it's in the plasma. Whereas pregabalin, it has linear absorption and hence increased bioavailability. So bioavailability wise, pregabalin is better as compared to gabapentin. The next drug I'm going to tell you about is phenytoin. It is used for partial and or GTCs also. The mechanism of action is voltage-gated sodium channel inhibition. Mode of administration is intravenous. So it has a lot of side effects. If we talk about side effects of phenytoin, we have to be cautious, like starting from the severe one like hypotension, arrhythmias, then it can cause Stevens-Johnson syndrome, lymphadenopathy, gingival hyperplasia is another side effect, hirsutism. Uske alawa we have purple glove syndrome. There's also osteoporosis, coarse facial feature, cerebellar atrophy is also a side effect, and hepatic failure and aplastic anemia also. Major metabolism occurs in liver, and it has zero order kinetics, like non-linear kinetics like gabapentin. Next is phosphonatoin. Phosphonatoin, now we will discuss, it's similar to phenytoin, but there are a few differences. Like phenytoin we give intravenous, but phosphonatoin we can give IV or intramuscular and intravenous both. It causes less hypotension as compared to phenytoin. Other side effects are dizziness, nystagmus, drowsiness. Okay, one important thing is it has fast loading rate. Like we can give it fast, but it first converts into phenytoin and then it works. So the rate of increase in the serum is same as phenytoin, but we can give it fast. So this is one important thing I wanted to discuss. Next drug I'm going to tell you about is valproate. Sorry if I'm going a bit fast, but you can just rewind if you want to listen something again. Because of shortage of time, I will just go through all these. So valproate is for partial seizures, for GTCs, for absence seizure, for myoclonic seizure, for West syndrome, infantile spasms जिसमें होते हैं, tonic spasms, tonic seizures. So mechanism of action are basically it causes sodium channel inhibitor. It's a sodium channel antagonist, T-type calcium channel antagonist, and agonist of GABA A receptor. We have both oral and IV options. It is enzyme inhibitor. Side effects include hair loss, acne, weight gain, irregular menstruation, PCOS, and other side effects are pancreatitis, hepatotoxicity, thrombocytopenia. So these are the side effects. It's important, I will repeat again: hair loss, acne, PCOS, irregular menstruation, pancreatitis, thrombocytopenia, hepatotoxicity. So these are the side effects. Mainly metabolism is in liver. Next is carbamazepine. Carbamazepine, oxcarbamazepine, carbamazepine. So these are related. So carbamazepine is used for partial as well as GTCs. Mechanism is sodium channel antagonism. Route of administration is oral. It is inducer, and it also causes autoinduction. Talking about the side effects, there is hyponatremia, there is ataxia, dizziness, rash, Stevens-Johnson syndrome, leukopenia, aplastic anemia, liver. It mainly has metabolism in liver. Nausea, vomiting are also its side effect. So due to autoinduction, we have to gradually increase the dose of carbamazepine, because it also like when one drug induces other, it reduces its levels. So we have to gradually increase the increase the dose of the drug. The difference between oxcarbamazepine or carbamazepine is that oxcarbamazepine is not converted to epoxide, and it can be titrated fast, and there is no autoinduction in case of oxcarbamazepine. A little bit about enzyme inducers and enzyme inhibitors. So you can remember the enzyme inducers and inhibitor by the mnemonic sickfaces.com. So sickfaces.com, this is a mnemonic for enzyme inhibitors. These are sick, like S, sodium valproate, I for isoniazid, C for cimetidine, K for ketoconazole, F for fluconazole, A for binge alcohol, C for chloramphenicol, E for erythromycin, S for sulfonamides, C for ciprofloxacin, O for omeprazole, and M for metronidazole. And beside this, we also have grapefruit juice. So, sickfaces.com. Sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, alcohol, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, metronidazole, and grapefruit juice. The others are enzyme inducers. The mnemonic for this is GPS. CRAP GPS. So CRAP is for carbamazepine, C for carbamazepine, R for rifampicin, A for alcohol, that is chronic alcohol, P for phenytoin, G for griseofulvin, P for phenobarbital, and S for sulfonylureas. So carbamazepine, rifampicin, alcohol, phenytoin, griseofulvin, phenobarbital, and sulfonylureas. These are the enzyme inducers. Now talking about the next drug. Next drug is phenytoin. Phenytoin we have already discussed. It's benzodiazepines. So I'll tell about clobazam. Basically, when we talk about benzodiazepine, there's a slight difference in the structure between benzos we normally use and clobazam. So benzos are used for partial GTCs, absence, myoclonic, status epilepticus, all types of seizures. Clobazam we use in LGS or maybe in focal seizures or as adjunct. Benzodiazepines are GABA A agonist. They cause activation of chloride channel, hence hyperpolarization of neuronal membrane. Side effects include sedation, aggression, constipation, UTI in case of clobazam. Metabolism is mainly in liver. Lamotrigine. Lamotrigine is used for partial and GTCs, partial seizure, GTCs, LGS, absence, myoclonics, almost everything we can use lamotrigine. It is also sodium antagonist, but also inhibits glutamate release. Side effects include dizziness, blurred vision, ataxia, Stevens-Johnson's, and epidermal necrolysis also. Mainly metabolism is in liver. Estrogens increase the clearance of lamotrigine, so we have to adjust the dose in pregnancy, as lamotrigine is comparatively safe in childbearing women. Topiramate is used for partial seizures, GTCs, absence, and LGS, Lennox-Gastaut syndrome. It also causes sodium channel. It's a sodium channel antagonist, GABA agonist, and AMPA antagonist. Dose is we take it orally. Side effects include paresthesias, tingling, acute angle closure glaucoma. Then we have renal stones, weight loss, decreased cognition, word finding difficulty. Renal excretion is the main mode of excretion. Okay. Next drug is lacosamide. So lacosamide we use for partial seizures. We can also use for GTCs. It causes slow inactivation of voltage-gated sodium channels. We can give it orally as well as IV. Side effects include dizziness, nausea, headache, and dose-dependent PR interval prolongation. Mainly, metabolism occurs in liver, and it also has renal excretion. So there are few more drugs that are a bit new, but it's good to discuss few lines about them. At least we should know their names or some few words about them. Perampanel. I'm not sure if I'm pronouncing it correctly. Okay. Anyways, ignore if I do not pronounce anything correctly. Main purpose is to get the point. Perampanel is a AMPA receptor antagonist. It has broad spectrum. 4 to 12 milligram is its dose. It's mainly absorbed, metabolized in liver. It has long half-life, 105 hours. Side effects are dizziness, somnolence, headache, behavior, intellectual changes, and homicidal thoughts. Next is eslicarbazepine. It's analog of carbamazepine. Inhibits sodium channel. It's for focal and GTCs both. Dose is 400 to 1600 milligram. It's a weak enzyme inducer. It does not cause autoinduction, and it can cause hyponatremia, and it can worsen absence and myoclonic seizures, and drowsiness, headache, rash. These are the side effects. Cannabinoids basically they enhance GABA activity, and it's mainly used in LGS and Dravet syndrome. Can be used in focal seizures and as an iron therapy. Mainly hepatic metabolism occurs. Hepatotoxicity, especially when we give other hepatotoxic drugs or other drugs that have mainly metabolism in liver. We have to monitor LFTs when we give them with valproate, and sedation and fatigue are also the side effects. And the drug is brivaracetam. It binds to protein SV2A. It's a mild sodium inhibitor. It is metabolized in liver. It can be given in oral IV, and it causes somnolence, dizziness, irritability, personality changes also. Cenobamate causes inhibition of voltage-gated calcium channel. It also acts at GABA receptors. It is used for focal epilepsy, but it is also enzyme inhibitor and inducer, so we have to be cautious while giving it. And somnolence, diplopia, multi-organ hypersensitivity, and QT interval shortening are the common side effects. Actually, we cannot remember everything on tips, but as much as it's possible, we should think about them. That okay, we need to remember them. So it's too much for today. Next time I will tell you about how to choose anti-seizure medicine, and most of the things I have written from different sources, and I also listened to a lecture from a university, Duke University, and it was very helpful in helping me during preparing for this topic, and I just want to share with you because I want to share the knowledge. There's no other purpose for sharing this.